Okay. Okay, guys. Okay. So thank you for coming. I was tasked to present at this conference in Kuwait under the umbrella of Kuwait Academy of Rare Disease Association, which is a newly established association. And in my presentation or the meeting would be held this Tuesday. And I was tasked to present or to talk about inherited arrhythmias and inherited cardiomyopathy. Obviously, it's a big topic, and I decided to target that topic in a more interactive way. So I would discuss an example or mention an example of an inherited cardiomyopathy, and then briefly discuss cardiomyopathy in general. And then I will present another case of inherited arrhythmia, and I will discuss channelopathies in brief. Okay. So when we say channelopathies, we usually it's another word for inherited arrhythmias, and then I would summarize in general what is cardiomyopathies and inherited arrhythmias. Okay. So, so case one. So this is a 15 years old girl who is who was largely asymptomatic except for vague fatigue with strenuous exercise, with chest tightness and muscle pain. She had an episode of dizziness and weakness as well, roughly a year and a half ago. Okay. So because of her vague symptoms, this prompted cardiac evaluation. And of note, she is a product of non-consanguineous parents or marriage, and there is negative family history of cardiac disease. Okay, so the ECG, like her ECG did was very abnormal. So what do you guys see? I mean, it's an relatively easy ECG. What do you guys think that ECG suggests? Oh. Anyone, guys? Like, what's the main striking pathology? Hello, anyone?
التي
There is
سيجمنت يا دكتور محمد.
inverted wave,
Sorry, I heard
ischemia.
Mirvet, you said what?
It looks like ischemia, inverted T waves, and depressed T segment.
Okay, a segment depression. Okay, someone else I said I heard QT, I think. Who was speaking? Well, I just you said ST. QT or ST?
اس تي يا
Okay.
دكتور، انا قلت على
Okay,
اس تي.
okay,
think
okay. So there's
ST
S6.
segment depression,
Yeah, but what else besides S segment depression?
inverted T wave.
Yeah, where?
I could see in AVS, in list 3,
Yeah, so there is inverted T waves
even
all the
list
way
2,
to V6, صح?
even list 2. Yes.
Right? So there's T wave inversion V6, V5, and the inferior leads, big voltage on the left precordial leads. Okay, so this is an ECG typical of what?
Hypertrophic cardiomyopathy.
Yes, thank you. Okay, so very suggestive of hypertrophic cardiomyopathy. Okay, so mainly, big voltages, big R wave in the left lateral leads, and with subsequent inverted T waves and edge segment depression. Okay, so indeed, the ECG was very suggestive, and the echo and MRI confirmed the hypertrophic cardiomyopathy finding, in addition to a scar that was noted on MRI. It was non-obstructive type. Mainly the patient was not hypertensive to explain that significant hypertrophic cardiomyopathy finding. And then she had very few PVCs on her Holter. Otherwise, she had no arrhythmias, and again, she was largely asymptomatic. So, whenever you encounter a patient who has unexplained cardiomyopathy, obviously genetic testing should be considered, and is actually the standard of care, okay? So this patient underwent genetic testing, which documented a pathogenic mutation in LAMP2, which is described to cause Danon disease. And this mutation, by the way, has been reported in the past and results in absent or very, very mutated protein. Okay, so loss of function of the function of that gene. Hence, there is zero protein, and hence it's most likely disease-causing and pathogenic, and again previously reported. Okay, parents were both negative, so she's a de novo mutation. And this is the first known case of Danon disease that I know of in Kuwait, okay? So really quick, what is Danon disease? It is a rare X-linked dominant metabolic disorder. So hence it is more aggressive in men versus, females. And the main clinical features usually are cardiomyopathy, mainly hypertrophic type. And there's also skeletal myopathy and some intellectual disability. And less commonly, there is retinal, hematological, hepatic, and pulmonary involvement, okay? Usually the thickness of the muscle is so severe, and the main morbidity and mortality comes from that that significant hypertrophy resulting in heart failure, and in addition, arrhythmia leading to sudden death and palpitations. So LAMP2 gene results, pathogenic or loss of function of LAMP2 gene results in deficiency of lysosome associated membrane protein 2 protein, which helps in digestion of aged cellular contents, including glycogen, and hence it's a metabolic disease, and organelles, including mitochondria. Okay, so the myocytes are unable to get rid of aged cellular contents. Okay, and hence this results in accumulation of vesicles containing that aged cellular contents, and also the inability to get rid of aged mitochondria results in mitochondrial dysfunction, energetic deficiency, and oxidative stress. Okay, so typically when you biopsy such patients, you will see vacuoles within the myocytes, and this is pathognomonic for Danon disease, and because of the immature autophagic vacuoles that are not digested or the cell is unable to get rid of. Okay, and this is predominantly found in cardiac muscles and skeletal muscles. Okay, it is a very rare disease. The largest study that I know of includes a multi-center European study, which only included 57 patients, okay, with pathogenic LAMP2 mutations. And as you can see, men are in blue and females are in red. As you can see, men present sooner and have more heart failure hospitalizations, more transplant, and more cardiac mortality, or sooner cardiac mortality. Okay, so for that cohort of 57 patients, 25% underwent heart transplantation and 25% died. Okay, so it's a very, very malignant disease, unfortunately, especially in men. Okay, and for extracardiac manifestations is very commonly seen in men, like we said, including myopathy, neurological changes, and visual changes, and so forth. Okay, so again, the extracardiac manifestations are more prominent in men and very uncommon in women, but it still complicates the picture and it might confuse the physician. Okay, and the cognitive disorder is not very severe, so it's usually mild, so especially in women. And in our patient, there's no cognitive deficiency that I could appreciate. Okay, and the father said that she's doing well in school, and she seems very smart as well. So again, the cognitive deficiency or disorder in Danon disease is very minimal, even in men. Okay, so when you encounter such patient, knowing the malignant nature of the disease, of course, you want to try to address the disease or the rapid disease progression, and also implement strategies for prevention of sudden death. Okay, so that's your main goal. Stop thickening of the muscle, and also inhibit arrhythmia, formation. Okay, so it is recommended for Danon disease to restrict them from exercise because there are Danon mice, models that result that with exercise training of those mice models, it results in an accelerated LV hypertrophy, dilation, and decreased EF. So exercise, at least on animals, has been shown to be disease accelerating. So exercise restriction should probably be very considered. And then also starvation should be also be avoided. So, encourage 3 meals per day, snacks and as appropriate, because again, Danon mice model treated with restriction of caloric intake resulted in impaired function and increasing fibrosis. So, you want to try to avoid cell death as much as you can, because again, when the cell is dying, with LAMP2 deficiency, you're unable to get rid of the aged cellular contact, and this results in disease progression. Okay, so again, exercise and starvation or decreased caloric intake should be best. It's best avoided. Of course, you want to balance that with, with the risk of being overweight and so forth. But in general, it's a balance. So try your best to balance exercise restriction and avoid starvation with obviously the obesity, risks as well. Okay. So so for disease progression, obviously you want to, like we said, you want to do lifestyle adjustments. In this case, exercise restriction and caloric intake, not limiting caloric intake. And then obviously you want to have low threshold to refer the patient to heart failure team to monitor the heart failure or the heart function. And then obviously you want to refer the patient to heart transplant evaluation. So just before, the severe decline of the function, or when the patient reaches the end stage. And for sudden death prevention, you want to obviously monitor for arrhythmias, religiously. So, have low threshold for loop implantation, for frequent Holter monitoring. You want to train the patient, and not the patient only, but the family of the patient BLS, maybe suggest AED at home, and, like wherever they are, wherever they're going, have consider ICD implantation. Obviously depends on specific findings that you might see on echo and MRI and Holter and so forth. But you want to consider ICD as well, for obviously for any hypertrophic cardiomyopathy patient, but especially for Danon disease patients. And luckily, there are gene therapy trials that are ongoing. So there is a phase 2 trial that has been recently approved by the FDA in 2023. And if this trial was successful, then hopefully there is an option to limit disease progression, and hopefully even remodel the heart back into normal. Okay, so there are positive, like the initial, there is some positive like results from the gene trial. So hopefully, if this was successful, Danon disease progression, prognosis would much improve. Okay. Um, so for this case, obviously, or whenever you encounter a patient and in this case, we suggest the patient had vague symptoms. Obviously, cardiac evaluation was done, and then with family history, we know there was no family history. So we wondered about if there's cardiac disease. You wonder about autosomal recessive disease or de novo mutation, and then the ECG imaging confirmed an unexplained severe hypertrophic cardiomyopathy, and then genetics explained the hypertrophic cardiomyopathy. And then thereafter, we did cascade screening, and then we knew that mom and dad were negative, and that's a de novo mutation, okay, for that patient, okay? And then obviously, knowing that she has Danon disease, we can accordingly treat that patient, and hopefully maybe she would be on she would be, one day she might get that gene therapy treatment. Okay, so knowing the exact cause of the hypertrophic cardiomyopathy is really beneficial. Okay, so in general, cardiomyopathy is a myocardial disorder that it's a muscle disease of the heart that results in abnormal function of the muscle of the heart. Okay, and the absence of coronary artery disease, hypertension, any valve disease, congenital heart disease, and so forth. Okay, so when you have an unexplained muscle disease of the heart, then this is called cardiomyopathy, and you have to explain that cardiomyopathy. In general, there are a couple of subdivisions of cardiomyopathies. Restrictive cardiomyopathy is one of them, hypertrophic cardiomyopathy is one of them, dilated cardiomyopathy is one of them. This is what we were taught when we were back in med school, but now there are newer classifications. ACM stands for arrhythmogenic cardiomyopathy, in which there is a predominant arrhythmia in that specific group of patients, and LV non-compaction cardiomyopathy. Okay, so this is one of the most accepted classifications of cardiomyopathies. But again, there are a couple of different classifications, but this is the classification that makes the most sense for me. Okay, and then again, there are genetic reasons or causes for such cardiomyopathies, and there are non-genetic factors for such cardiomyopathies, but you have to rule out genetic etiology. Okay, so when you have a patient with a cardiomyopathy, obviously it's a teamwork. You really wanna have a heart failure cardiologist, arrhythmia cardiologist, um, cardiac imagers, a geneticist, maybe pathologist, and psychologist, and so forth. So it's a team effort. And unfortunately, we don't really have this here in Kuwait, but we hopefully one day we would have that. So it requires multidisciplinary team approach, and because these patients are very complex and they truly require care from many different types of cardiologists. Okay. So any quick questions regarding cardiomyopathy? So that presentation is meant to be given to a conference that is like the day after tomorrow. So I will not go into details because that conference is meant for geneticists. So I did not go into super details, but that's in brief. Whenever you encounter cardiomyopathy patients, this is how you classify the cardiomyopathy, and obviously if it's unexplained, you really have to do genetic testing and then go from there. Okay, guys? So that Danon disease is very, 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 very rare. Okay. And that's the first, patient that I do have. Okay. Questions, guys? Okay. So, case 2. Okay. So again, I was tasked to talk about cardiomyopathy and also talk about channelopathies or inherited arrhythmias. Okay, so that's an example of a channelopathy patient or inherited arrhythmia patient that we also encountered like semi-recently. Okay, so this was an 11 years old who was walking outdoors, had an unprovoked collapse. Okay, he was found pulseless, CPR was started, he was defibrillated twice before return of spontaneous circulation, but he was thereafter, he remained unconscious. He was bradycardic with metabolic acidosis and high troponins, high lactates, and pH of 7.06. He went to the ICU, obviously. He was very sick. He was a product of consanguineous marriage, but there was no family history, sorry. And he had a normal echocardiogram, and in the ICU, he had 2 ventricular tachycardia episodes while on dobutamine because again he was bradycardic, and he had frequent premature ventricular beats that are polymorphic, especially when he is stressed, meaning when he's light on sedation or after he was extubated and being nervous for a certain test, for example. Okay, so that was his ECG, initial ECG after he was shocked out of his initial rhythm, which presumably was VF. So what do you guys note on that ECG, the most striking feature of that ECG?
prolonged QT segment.
Yeah, so the QT is definitely generous, prolonged. Mind you, that's an ECG post-resuscitation. So sometimes just because the patient is very sick, the QT might prolong, but that's definitely, it's something to take a note of. So the QT is definitely long. And remember I said he had 2 VT episodes in the ICU. So this was one of his VT. The other one was exactly the same. It's a VT that is, not monomorphic. Look at V3. You can see my pointer, right? So, in V3, it definitely does not look monomorphic. But it's a narrowish VT, but definitely also in, lead 2 here. So definitely polymorphic, narrowish VT. Okay. That the patient was shocked for, and he became unstable during. Okay. Um, so, and then these are his ventricular ectopy that he had, especially when he's light on sedation or under stress. And what do you guys see? They are not monomorphic, right? They are polymorphic, right? Right? So this is down going, down going, down, and this is up going, for example. Okay, and different than his VT. So when you see any QRSs that are down going and up going in the inferior leads or the limb leads, these are called bidirectional PVCs. But again, the point here, they are polymorphic PVCs, which might mean something. So this patient had a normal cardiac MRI, but he had so much PVCs when he was not intubated. So we had to suppress his activity by intubating him, fully sedate him to suppress those PVCs, because otherwise the PVCs were very prominent, and we canceled his cardiac MRI once or twice because of the prominent PVC. So again, when he's stressed, he was worried about the MRI, he gets these PVCs. When he's obviously under anesthesia, the PVCs get suppressed, okay? So we did, because it was unexplained cardiac arrest, whenever you encounter unexplained, like we said, whenever you encounter unexplained cardiomyopathy, you want to do genetic testing. That's the standard of care. Here as well, whenever you encounter a patient with unexplained cardiac arrest, so for example, in this case, there's not, he did not get, like, tox screen was negative. There is no explanation for why he had an arrest. Okay. So arrhythmia panel was done. However, it was negative. Okay. So it was an extensive arrhythmia panel, and it was negative. So this got us semi-confused. Because it was unexplained cardiac arrest, we had implant an ICD on him before he went home. And then it was a dual chamber, system, because remember, he had bradycardia. So we wanted to atrial pace, and because he would probably require medications, of course. So we implanted an ICD. We started him on nadolol, which is a beta blocker, and then BLS training. Remember, when he collapsed, he fractured his leg, so we could not do a stress test. We did everything except a stress test because he had leg fracture. You could argue we could have done medical stress test, or we could infuse epinephrine, for example, or something that elevates his heart rate. But we knew, based on his story, that stress causes ectopy. So that was an indication that stress test might not be normal for him. But we discharged him with an ICD. We waited for his fracture to heal, which was a fissure fracture, so it healed up quickly in 3 weeks. And the diagnosis was uncertain, but we had something in mind, but was definitely unconfirmed. And before showing the stress test, so we were obviously thinking heavily what might explain his presentation. We know that he was a product of consanguineous marriage. So maybe he has an autosomal recessive disease because the family was negative. So maybe it's an autosomal recessive disease where there is, minimal family history, or a de novo mutation like the initial case. We remember I did not show you those, but the ECGs for both parents were normal, by the way. There was no long QT or ectopy. Okay. So we know that his QT interval is on the higher side. So we wondered about long QT syndrome. Okay. But the VT and the ectopy is not very typical of your long QT syndrome, the most common long QT types. Okay. So that ectopy did not make much sense. We know that he arrested while being active, although very slightly, and he had VT while on dopamine, and he had PVCs while being anxious. So this made us think of catecholamine-mediated polymorphic ventricular tachycardia, CPVT. Okay, guys? So now we were thinking, is it long QT syndrome? Is it CPVT? Is it both? But the arrhythmia panel came back negative, remember. So this is his stress test. You know, we are atrial pace here. Do you guys see the atrial spike? Pacing spike? You see it here, guys? It's a small spike.
Yeah.
Yeah? Everyone see that? Okay, so there's a small pacing spike followed by a P wave, okay? So the patient's atrially paced, again, because he was bradycardic. So what do you guys see mainly on that ECG? This is before he started running. Guys.
Inverted T wave. T wave inverted. It looks like
Yeah, يعني T waves definitely abnormal repolarization صح؟ So V4, V5 يعني it's a abnormal T wave morphology صح؟ Lead 2, 3, AVF all are inverted صح؟ Okay? Okay. So repolarization is definitely abnormal. It doesn't measure as long as it used to be, but definitely remain. Okay?
yeah.
Okay. So now he started running, and this is what we see. What do you guys see?
Some PVCs.
Yeah. Can you be more specific?
It is first by Gemini, I think.
Yeah. Are they monomorphic or polymorphic?
Bidirectional?
Later polymorphic.
Yeah. So yeah, bidirectional polymorphic PVCs. Okay. For example, here. Okay. For example, here. Okay. So he definitely have, for example, here. Okay. If we definitely have upgoing, downgoing
Yes.
PVCs on his limb leads. Okay. Okay. So, this is at peak exercise. Remember, he was already on Nadolol. Okay. Beta blocker, so we did not see so much, but still there is PVC that are bidirectional. Okay, so again, suggesting CPVT. Okay, okay. This is his brother because remember we had genetic testing that was negative, so we have to screen the entire family because we don't know what we are. There's no genetic testing that we could rule in or rule out a specific disease. We have to screen the rest of his siblings. He had three more siblings. Okay, so that's one of his brothers who is a 14 years old asymptomatic. This is at peak exercise, 14 years old at heart rate of 151. Again, his initial ECG was fine, and this is what he was doing when he was exercising before he gets tired. What do you guys see?
Also, there is PVCs.
Yeah, again, be more specific.
Also, I think it's the same.
Yeah, يعني again polymorphic bidirectional. Okay, صح? Okay.
Yes.
So again, his brother, who is not on many medications, who is asymptomatic, is doing this while on exercising, and then he tells me I'm tired. Probably this is partly why he's getting tired, but he's denying palpitations. Okay. So again, the brother, I did not show you the brother ECG at rest, because again, I had only half an hour to present, so I wanted to be very brief. But anyways, the brother QT was normal. Okay, so the brother, the brother stress test is classical for CPVT, and he had a normal echo, by the way, normal resting ECG. Okay, okay. So just really quick, CPVT is a rare cause of sudden cardiac death in the young, okay? The hallmark arrhythmia is bidirectional VT, okay, or PVCs. It's very high risk, very penetrant disease. And if you don't treat the patient by 40 years of age, 30% or third of the patients that are untreated will die by 40 years of age. Okay, so it's very penetrant disease, much more penetrant than long QT syndrome, okay? And so this is why, CPVT patients, we really respect them and we try to treat them and recommend treatment and be aggressive with treatment because it's very highly penetrant, highly mortal, high mortality disease. Okay. There is, the patient is usually very normal in terms of cardiac morphology, in terms of echo findings. There might be minimal bradycardia, sinus bradycardia, and there might be some intellectual, learning difficulties, but it's usually very minor. Okay. So it's relatively easy to diagnose. You just diagnose CPVT in a patient with normal heart, normal ECG, and exercise or emotional induced polymorphic bidirectional VT. Okay. Or if the patient has a pathogenic mutation in a gene that is known to cause CPVT. Okay. So, so our patient met the criteria for CPVT diagnosis. Really quick, with CPVT, there are typical forms and atypical forms, okay? So typical forms are your classic CPVT, in other words, normal ECG at rest and bidirectional VT at exercise, okay? A normal ECG at rest, okay? And then usually roughly 75% of typical CPVT patient will have RYR2 gain of function mutation or calsequestrin 2 mutation, okay? But usually RYR2 gain of function mutation, okay? Okay, but there are atypical forms. They are very rare, less than 20%, 15% of CPVT patients are atypical. And then the known genes that result in atypical CPVT are those 4 genes in short, triadin, calmodulin 1, 2, 3, tecrol, or RYR2 loss of function mutation. Okay, but they are very rare. Okay, so these atypical CPVT patients, they do have abnormal baseline ECG, like repolarization is usually funny, abnormal. And the exercise testing may or may not be very classical in terms of bidirectional VT, okay? But anyways, they get VF and they die suddenly as well. Okay, so the chakral, by the way, stands for trans 2,3-enoyl-CoA reductase-like. And then like if you just to remind you, we did arrhythmia panel for the patient and it was negative and it included RYR2, calsequestrin, triadin, and calmodulin, but it did not include tecrol. So when I looked up the arrhythmia panel, I noted that tecrol was not in the panel. Okay, so the question remained: is he a tecrol patient that was not tested? Okay, so we wanted to rule out tecrol. Okay, um, um, okay, so. Remember our patient had also long QT prolongation as well, or QT prolongation as well. So when you encounter a patient with CPVT plus QT prolongation, tecrol actually causes that combination. Okay, tecrol results in abnormal repolarization and CPVT phenotype. Okay, and then remember he had a brother as well who was clinically the same in terms of stress test. So we know there's something inherited, of course, because 2 siblings, one arrested, one had polymorphic VT with exercise. There must be something inherited, families, consanguineous, and so forth. Okay, so tecrol is a suspect, and then it's an autosomal recessive disease. Okay, so again, it fits the patient very well because the parents are consanguineous. Okay, the triad knockout syndrome, CPVT is also somewhat recessive, but again, we ruled it out by having negative genetic testing. Calmodulin is an autosomal dominant disease. We ruled it out already. And then there's another differential where it causes long QT phenotype plus CPVT phenotype is Anderson-Tawil syndrome, which is long QT type 7, but they do have usually dysmorphic features, and it's autosomal dominant. And anyways, we ruled it out by doing the genetic testing, which included KCNJ2. Okay. So anyways, so we still, Tecrol is a suspect. Okay. So remember, we said arrhythmia panel is negative, but then we had to rule out Tecrol so we ordered whole exome sequencing to rule out Tecrol. Okay. And then indeed, Tecrol was, the patient was homozygous and positive for Tecrol, and with a pathogenic classification. So that mutation was previously published and reported, and it was classified as pathogenic or disease causing. Okay. So this is a patient who presented with cardiac arrest. The family history was suggestive of either autosomal recessive disease or de novo mutation. His ECG imaging workup was suggestive of CPVT long QT combination, but predominantly CPVT phenotype. His genetics confirmed atypical form of CPVT. Cascade screening confirmed the brother being positive. Mom and dad were both heterozygous, so they don't manifest the disease, and it's a very, very rare atypical CPVT variant. Okay, there are only 17 families known to date. 17 families, and their phenotype is very heterogeneous. Usually they present young, they have QT prolongation, they have ventricular ectopy, may or may not be bidirectional. And be aware that Tecrol, because very rare, it's not routinely tested in commercially available panels. So if you have high index of suspicion, you have to ask for it, you have to look for it, you have to rule it out. Okay. And we eventually published this case as a case report so that, people just are aware more aware of it. Okay. And the patient was started, in addition to Nadolol, we added flecainide so that to inhibit the ectopy. Okay. Anyways, so for channelopathies, it's an inherited arrhythmia disorders, but primary electrical disease, okay, affecting ion channels of the cardiac myocytes and predisposing to sudden death, okay? So they are largely genetic in etiology, and there is rarely any cardiac muscle involvement. So that's the definition of channelopathies, okay? And then the classical examples of channelopathies are long QT syndrome, CPVT, Brugada, short QT syndrome, early repolarization syndrome, and so forth, okay? So when you encounter a patient who arrested or survived and has a normal imaging phenotype, of course, channelopathy is, you have to rule out a specific channelopathy, and these are the main channelopathies that you should look for and rule in or rule out. Okay, and again, genetic testing is a standard of care. Okay, so. So in brief, when you encounter, again, sudden cardiac arrest death patient, and you're a cardiologist and you want to rule out cardiac etiologies, obviously you want to make sure there's no myocarditis, intoxication, electrolyte disturbances, commotio cordis that might resulted in the collapse. Okay, commotio cordis, you guys know what commotio cordis? It's like when someone is hit at the chest in a specific period of time where the cardiac electrical system is vulnerable, and that results in VF. Okay, you heard of it, guys? Commotio cordis? If you did not, it's something that to look for when you get a history of like a chest injury, then sudden arrest. This might be commotio cordis. Okay, and anyways, and then if you don't think it's myocarditis, intoxication, electrical disturbances, and so forth, then you want to think of genetic etiologies. For example, cardiac conduction disorders. For example, if someone has a cardiac conduction disease that causes severe sinus node dysfunction or severe AV node disease, it might result in significant bradycardia, and this might result in asystole or cardiac arrest. Okay, or You want to rule out various cardiomyopathies like we mentioned and various channelopathies like we mentioned, okay? Obviously, you want to image the heart of the patient and make sure there's no mitral valve disease, which is sometimes associated with ventricular tachycardia, coronary artery anomalies, which result in, sorry, coronary artery anomalies, which results in which might result in, coronary, damage and ischemia, and then, ventricular tachycardia or VF, or any obstructive lesion that might result in decreased cardiac output and patient collapse. Okay. Obviously, aortopathies are something that you want to rule out as well. That aortopathies resulting in in rupture of large vessel, and obviously WW patients are at risk of sudden death as well. So one presentation of WW is cardiac arrest. So if you see the ECG and you were able to identify a delta wave and short PR, this might be the result of the patient cardiac arrest. But these WW patients are there is usually no family history and usually not genetic disease, okay? And obviously severe dyslipidemia, like genetic dyslipidemia, might result in premature coronary artery disease and ischemia and sudden death as well, like the adults, okay? And then if you rule out everything, then obviously it's idiopathic, and there are patients with idiopathic VT/VF that no one understands. Okay, okay, and then obviously non-cardiac causes do exist, so someone else has to make sure they are not the reason for it's not the reason for the cardiac arrest. Okay, guys. So in summary, cardiomyopathies are abnormalities of the heart function, muscle function. Inherited arrhythmias or channelopathies are abnormalities with the cardiac electrical system. Okay. And then whenever you encounter someone with potential cardiomyopathy, potential inherited arrhythmia, you want to refer to electrophysiology service to, complete the workup and do the genetic testing, and hopefully diagnose the patient with a specific mutation that explains the cardiac phenotype. Okay. And obviously cardiomyopathy and inherited arrhythmias both might lead to cardiac arrest and death. Okay. Okay. So this is part one of the presentation. Let me, Abbas, just a second. Let me stop. Sorry. I will stop recording. Abbas, are you ready?